Okay, good afternoon, everyone. Again, this is Bill Riley with Medical Advantage Group, and welcome to our latest CPC Plus webinar. Today we're going to be talking about improving quality of care with Shelby Courtney. Before we get into the material, let me cover some housekeeping real quick. We've got a lot of people dialed in today, and with that, we're going to keep the phone lines muted throughout the whole presentation. You will be able to submit questions. Please use the question area of your GoToWebinar control panel to submit anything you'd like to talk about, and we'll address those towards the end of our session. After the webinar, as always, anyone who's participating today, along with anyone who RSVP'd, is going to get a copy of these materials as well as a recording of this session. So before I hand it over to Shelby, let me just do a brief introduction. Shelby is one of our senior practice transformation coaches. For many, many years has been meeting directly with different physician practices that we support here at Medical Advantage, leading them towards implementing improved quality and best practices. I think she's definitely a leading thinker, a leading resource in this area. The client feedback we get about Shelby from both physicians and office managers, some of whom I think we can see on the line here with us today, is overwhelmingly positive. We often have a hard time once Shelby gets into a practice, getting her out. She's appreciated so much. So I think it's going to be a great session today. Thank you, Shelby, for joining us. And with that, please take it away.
Thank you, Bill. So first of all, congratulations to everyone. First and foremost, being selected into the CPC Plus program is a very prestigious program, and so we just want to congratulate you again. But now that you're in, it's time to focus on how you're going to be successful. So the objectives of this webinar today is for you to gain a practical understanding of the CPC Plus program. We're going to explain some of the ECQM reporting requirements, understand quality measures required for the CPC Plus tracks 1 and 2, and then know how the quality measures impact your CPC Plus payments. I also do want to identify that a large focus will be looking at the quality measures, understanding all their components, and to help you assist in identifying any deficiencies you may have. So CPC Plus will be the nation's largest multi-payer initiative to improve primary care, which spans over 5 years and includes multi-payers and includes 5,000 primary care practices. The goal of the CPC Plus is to improve the quality of care patients receive, improve patients' health, and spend health care dollars more wisely. The care delivery model that CPC Plus has is the basic capabilities of the practice, up-to-date technology, testing a non-traditional payment model to understand if it supports better care for patients. Some of these things that you'll see in the care delivery design, it's like we've talked about, is improvement in 5 primary care functions, the use of technology that supports those functions, and then they reimburse for the practice's work that may not otherwise be compensated for in the fee-for-service system. So the practice benefits: increased reimbursement to provide better patient care, experience with evolving payment models. It qualifies the practice for participation in an advanced alternative payment model under MACRA, otherwise known as the APMs. So the APMs for 2019 through 2014, participating practice would be excluded from the merit-based incentive program, the MIPS, reporting requirements, and payment adjustments. They also qualify for a 5% APM incentive payments for Medicare. All right, so practice responsibilities to report the quality. So this is the quality side that we're going to look at. For quality metrics, practices need to comply with certain tasks specific to reporting. They must meet certain certified health IT requirements. Certain measures must be reported electronically directly from your EHR or use specialized software. For prospective financial incentives to continue, you must meet performance benchmarks, or the practice will have to return money to CMS. For a refresher, all of you have to be using certified electronic health technology to be eligible to be selected for the program. You need to maintain use of that certified technology. For both track 1 and 2 practices starting 2017, you must be using 2014 or newer certified EHR technology. However, starting in 2018, you must update to the 2015 or newer. The most important measure to implement right now this month is the ECQM. If you have not done so, you need to contact your vendor and work with them to ensure the ECQMs you plan to monitor are in your EHR. If you have not done this step, please do this ASAP. So right now we have a couple of polling questions that we would like for the audience to answer. If you could do that. Okay, and you should see the polling questions out to you, a simple yes or no. Well done. Okay, so it looks like in the first question, it looks like everybody has identified what their ECQM measures are. So that's great in their EHR. And then in the second question, if you can see that one, it talks about if you have confirmed with your EHR vendor of those ECQMs and if they can actually report them successfully. Okay, so great. It looks like 71% are saying yes, they have done all their homework in regards to their ECQM reporting with their EHR vendor. Fantastic. All right, as we move on, we're looking at the quality and utilization measures. There are 2 components that tie to the performance-based incentive payment, quality and utilization. Quality includes a patient experience of care survey and 14 electronic clinical quality measures, also called the ECQMs. Utilization includes emergency department visits and inpatient admissions. For the next one, for patient experience of care, CMS will conduct an annual survey on a sample of your patients using the Consumer Assessment of Healthcare Providers and Systems, otherwise known as the CAPS, Clinical and Group Patient-Centered Medical Home Survey. CMS will cover the cost of the survey. The patient sample will include Medicare, Medicaid, and commercial members. Your practice will be required to provide a patient roster to CMS. This is used in sampling your patient population. We don't know exactly when the survey will be conducted, but of course anticipate later in the year. Make sure that you're keeping up on all the CPC Plus newsletters and webinars as more details are announced regarding the survey. When we look at claims-based utilization measures, they're going to be looking at your ED visits and your hospitalization utilization. Medicare claims are used to determine your emergency department utilization and inpatient hospital utilization, which is based on HEDIS criteria. ED visits are limited to outpatient visits. They do not result in hospital admissions, so that emergency department visits resulting in a hospitalization are not counted in both utilization measures. So again, multiple ED visits will only equal 1 visit per day. The exclusions that come along with this is that mental health, chemical dependency, psychiatry, alcohol or drug rehab, or detox. You can see some of those measures in there. So hospitalizations are the largest driver of total cost of care at averaging of over 35%. This is actionable and can be reliably measured at the practice level on paid claims. So calculated at the practice level by CMS, so no reporting is required by the practice, Medicare beneficiaries age 65 and older that are attributed to the practice is what will be included. These patients will be risk adjusted for age, gender, and comorbid conditions. Additional measures may be added in later years as the program progresses, but right now they're just looking at your ED and hospital utilization. All right, when we look at the third component, we're looking at ECQMs. Your practice must choose and successfully report 9 of the 14 CPC Plus electronic clinical quality measure sets for the 2017 performance period that begins on January 1st, 2017 and ends on December 31st, 2017. This is why it's important for you to identify the measures ASAP if possible so that your EHR can report on them. You also want to begin tracking your performance throughout the year. However, CMS encourages you to include all 14 measures in your EHR This will ensure your practice is able to report the required 9 measures in the event one or more of the ECQMs is removed from the list due to future events, such as changes to clinical guidelines. This would have an impact on how you're reporting. So for instance, if they decided to remove one of the quality measures that you were tracking, you would have to substitute a different one. So you're better off making sure all 14 are in there and tracking them and pulling reports and monitoring those at the same time. All measures must be reported at the practice level using the April 2016 version of the electronic measure specifications as identified in the CPC plus ECQM measure set. Reporting must include non-Medicare fee-for-service patients at the practice. The measure specifications are updated at least annually and are located in CMS EQM library. All elements for the ECQMs must be reported to be considered a successful submission. So you have numerator, denominator, exclusions and exceptions, if that's applicable, and performance rate to meet the requirements. So again, some measures may have multiple reporting requirements, and all must be reported. It is important to read and know the measure specifications so you know what is being pulled for reporting. All right, so now let's dive into some of the ECQM specifications. Right now we're going to look at the ECQMs in Group 1. All the measure specification, unless stated otherwise, are derived from the National Quality Forum. The ECQM library has all the measure specifications for the ECQM measures. We're going to look at each of these measures closely. The EQM library on the CMS website has detailed information on each measure and the NQF guidelines. You'll want to know how your patients are being identified and flagged for reporting in your EHR, how to prove it, and what specs need to be reported. Group 1 measures are the outcome measures. You must choose 2 of these 3. The next three slides will look at each measure in detail. So the first one we'll look at is depression remission after 12 months. According to the National Institute of Mental Health, 6.7% of the U.S. population ages 18 and older in any given year have a diagnosis of a major depressive disorder. Major depression is the leading cause of disability in the U.S. for ages 15 to 44. Additionally, dysthymia accounts for an additional 3.3 million Americans. So the measure, when you actually look at it, it requires that patients age 18 and older with major depression, with a diagnosis of major depression or dysthymia, an initial patient health questionnaire, so a PHQ-9 score greater than 9, who demonstrates remission at 12 months plus or minus 30 days, defined as a PHQ score less than 5. So basically what you're looking at here is that you've got initial diagnosis of major depression or the dysthymia. You've given them a PHQ-9 score, and it's greater than 9, and then you get the patient back in and you reassess the patient after 12 months, give or take, plus 30 days, and their score is less than 5. This is how you would have to meet that measure, is getting that patient back in. So again, 12 months is defined as the point in time from the date that a patient meets the initial population inclusion criteria. So their diagnosis of the PHQ score is greater than 9. Then you extend it out 12 months, and you allow for that grace period of the 30 days plus or minus, and then your score would have to be less than 5 during that 2-month period. The measure applies to both patients with newly diagnosed and existing depression who currently have a score of 9 in their PHQ-9 assessment. This aligns with Function 3, comprehensiveness and coordination, and integrating a behavioral health condition into primary care practices. So if you're going to do this, this is a great one for if you're in the Track 2 to look at incorporating this with your behavioral health. You want to target patients with chronic conditions such as cardiovascular disease, diabetes, asthma, obesity, as these conditions have higher rates of depression. One of the questions I like to ask the practices when they say that they are currently doing this is, can you run a report showing what each patient's PHQ-9 is? Some EHRs have had some issues with reporting those PHQ-9 scores. They can say, yes, an assessment was done. Yes, they have the diagnosis of major depression, but they cannot run and actually show what the PHQ-9 score. So that would be something you would want to check with your EHR vendor. When we look at controlling high blood pressure, I'm sure most of you are currently doing this measure. But again, it's the percent of patients that are 18 to 85 years of age who have a diagnosis of hypertension and whose blood pressure was adequately controlled, so you're looking at less than 140/90 during the measurement period. We do have some exclusions in here, so patients with evidence of end-stage renal disease, dialysis, or renal transplant. So make sure you're excluding all those patients that are can be excluded out of these when you're doing your reporting. If the blood pressure was not done during the measurement period, then is not considered in control, and it will hurt your score. If there are multiple blood pressure readings on the same day, you want to use the lowest systolic and the lowest diastolic reading as the most recent blood pressure reading. So if that is something that your practice is used to doing, where they will take multiple readings, my next question for you is to make sure, how does your EMR pull that information? Some EMRs will only pull that initial reading, so that's a good question to ask them, is do you only pull the initial reading? So we got to develop a workflow around that, or do you pull, will they particularly look for the last reading? So develop the work process around that. The next one is to look at diabetes. So this is a diabetes where we're trying to keep patients in control. So this one actually is measuring for poor control. The CDC estimates that by reducing A1C blood levels results by 1 percentage point, so from an 8 to a 7, this will help reduce the risk of microvascular complications, so eye, kidney, and nervous disease, by as much as 40%. A patient is numerator compliant if their most recent HbA1c level is greater than 9%. The most recent HbA1c result is missing, or if there is no HbA1c test performed and the results documented during the measurement period. If the HbA1c test result is in the medical record, the test can be used to determine numerator compliance. Only patients with a diagnosis of type 1 or type 2 diabetes should be included in the denominator for this measure. Patients with a secondary diagnosis of diabetes due to another condition should not be included. Again, so obviously when you're looking at this one, you're looking for a lower score is better. We want our patients in control, not 9 or above. This is another measure where protocols should be set up to follow up with patients between appointments to assure compliance with medications, diet, and exercise. It's also important to identify any barriers patients may be having, so affording medications, accessing to healthy foods. So doing that care management service in between these appointments is going to be vital for these patients. So again, we want this number to be as low as possible. Looking at the ECQM group 2, these measures are the complex care measures. You must report 2 of the 4 measures, but ideally you should track all 4. When you're looking at the use of high-risk medications in elderly, they're using the American Geriatric Society of Beers criteria. So the specifications include the percentage of patients 66 years of age and older who were ordered high-risk medications. There's 2 rates that are reported, a percentage of patients who were ordered at least 1 high-risk medication, and then percentage of patients who were ordered at least 2 different high-risk medications. Again, this is one of those ones where you want your score to be lower, so lower is better. High-risk medication is identified as either of the following: a prescription for medications classified as high risk at any dose for any duration, or prescriptions for medications classified as high risk at any dose with greater than a 90-day supply. Some of the things you want to consider here when you're in the practice is, does your EMR, your EHR confirm, or do they somehow trigger you to know which patients are on a high-risk medication? Do they flag them for you? If they don't, how can you develop a process to find out which patients are on these high-risk medications? Some things that you could consider is making sure that you're doing complete medication reconciliations annually or after an inpatient stay within 30 days. And that includes the patients bringing in their, as you would say, their windowsill amount of medications to go over all of them. You want to consult with your pharmacist to discuss meds with the patients during any planned care visits. And then also consider using some of your commercial payer med lists, because they will usually identify patients that are on a high-risk medications. So because we can report in the ECQMs, if you're EHR, the biggest thing is just how to identify these patients that are on this. The next one is dementia, cognitive assessment. So this one reads that percentage of patients, regardless of the age, with a diagnosis of dementia for whom an assessment of cognition is performed and the results reviewed at least once within a 12-month period. So what they're saying is you need to use a reliable and validated instrument, and we've listed some of them here that they recommend. These aren't the only ones. You can pick some different ones. You should be running reports using your diagnosis code for dementia to figure out which patients population actually have this diagnosis. And then you need to make sure that you're running a cognitive assessment on them, and then you're making sure that you followed up within that 12-month period. One of these things that you need to make sure that your EMR or EHR does here is that you're recording the assessment. Is it going in a discrete data field? So yes, the patient is here. Yes, they have dementia, and I've done a cognitive assessment on them. I put it in a discrete data field. Does your EHR have an assessment already built in? Maybe it's hidden within there, but you want to find that. So do they have one built into your EHR, or do you need to go find a document and we print it, scan it to the chart, however your process works? The other idea is to perform this assessment during their annual wellness visits. All right, next we have fall risk screening. Many of you, I believe, should already be doing this as well. This one is for older adults. They're 5 times more likely to be hospitalized for fall-related injuries than any other cause-related injury. According to the CPC, it is estimated that 1 in every 3 adults over 65 will fall each year. Identifying at-risk patients is the most important part of prevention. So measures to avoid a fall can be implemented. The measure reads that patients 65 years of age and older who are screened for future fall risk during the measurement year. Assessment of whether an individual has experienced a fall or voices problems with gait or balance. A specific screening tool, it's not required for this measure. However, they do give some suggestions of using like the Morse fall scale and a time get up and go test. So you need to make sure that you're using a reliable fall risk screening tool, one that can either be in your EHR currently, or if you have to print one off and then scan it in. You also want to refer patients to balance and strengthen classes if they are at risk for falling. So dependence treatment. So this is initiation engagement of alcohol and other drug dependence treatment. Reporting are the percentage of patients 13 years of age and older with a new episode of alcohol and other drug dependence who receive the following. 2 rates are reported: percentage of patients who initiated treatment within 14 days of the diagnosis, and the second one is percentage of patients who initiated treatment who had 2 or more additional service with an AOD diagnosis within 30 days of the initiation visit. So these are one of those protocols where you have to complete 2 of them. The treatment includes inpatient AOD admissions, outpatient visit, intensive outpatient encounters, or partial hospitalization. They may require coordination of care with a specialist, such as a mental or behavioral health, to capture these patients and monitor their care. There are exclusions for this measure in the technical specs. This measure ties into comprehensiveness and coordination function, which has a behavioral health component and requires collaborations with other specialists. So again, as you start looking at this, a lot of this is about coordination of care with your patients when we're tapping into other specialties along with it. All right, for ECQM Group 3, you must choose 5 from Group 3 or the other 2 groups to equal a total of 9. So we want to make sure we get our total of 9 in there. You can access the technical specifications again on the ECQM library on the CMS website, which were updated in January. Next, we're going to be looking at the closing of the referral loop. This is when we're referring out to all our specialists and closing that loop. So we're looking at percent of patients with referrals for which the referring provider receives a report from the provider to whom the patient was referred. So this is patients of any age. Patients that have multiple referrals, you would just use that first referral. You wanted to monitor referrals submitted late in the year to ensure consult report received before submission deadline. So if you refer somebody out to a mammogram, something like that, when you're looking at October, November, making sure you follow up that you have that report by your submission deadline. Even in patient completes their test in December, you need to make sure you have that in time for reporting. Percentage of patients with referrals, regardless of age, for which the referring provider receives a report from the provider to whom the patient was referred. So again, make sure it's that initial referral that's going out and that you get the report back. You want to make sure you have a tracking log, or some way to monitor and follow up weekly. Assign this to a task to a staff member to follow up on all of these referrals that go out. Cervical cancer screening. We're looking at the percent of women 21 to 64 years of age who were screened for cervical cancer screening using either of the following criteria. Women that are age 21 to 64 who had a cervical cytology performed every 3 years, and women age 30 to 64 who had a cervical cytology human papillomavirus testing performed every 5 years. There's denominator exclusions that apply, those women that have a hysterectomy and cervix removed. One thing that we want to make sure is that we're emphasizing this with our OBGYNs. If you can make connections with those that are with the patient's OBGYN and help coordinate these activities, we'll have greater success with your patients. Early detection and treatment is key to survival when this is early detected. We want to target GAPS outreach on an annual basis. Again, when we're looking at the targeted GAPS outreach, reach out to the patient's OBGYNs to assist with the coordination of this. Colorectal cancer screening. This applies to patients that are 50 to 75 years old. The United States Preventive Service Task Force has identified fecal occult blood tests, FOBT, colonoscopy, and flexible sigmoidoscopy as effective screening methods. Patients with a diagnosis or past history of total colectomy or colorectal cancer are excluded. So this one you guys have been tracking for a long time, so nothing changed to this. Just continue to educate patients on the importance of colorectal cancer screening, running those patient reports to get them in early to educate. Breast cancer screening. This is for a percentage of women that are 50 to 74 years of age who had a mammogram to screen for breast cancer. Women who had a bilateral mastectomy or who had a history of bilateral mastectomy or for whom there's evidence of a right and left unilateral mastectomy are excluded from this. Again, you want to target your outreach annually for these patients and reach out to their patients' OBGYNs to help coordinate the outreach with them to ensure that these patients are getting these services needed. Next, we look at diabetic eye care. This is the percentage of patients that are 18 to 75 years of age with diabetes who had a retinal or dilated eye exam by an eye care professional during the measurement period, or a negative retinal eye exam in the 12 months prior to the measurement period. Only patients with a diagnosis of type 1 or type 2 diabetes should be included in the denominator of this measure. Patients with a diagnosis of secondary diabetes due to another condition should not be included. The eye exam must be performed by an ophthalmologist or an optometrist. Again, you want to make sure that you do a look back, that they do not have a result of a negative retinopathy in the prior year. Some EMRs, you need to make sure that that is set up that way and that your staff member are knowledgeable that if it was negative in the prior year, they do not have to have it in the current year. Use of imaging studies for low back pain. So this basically is on patients 18 to 50 years of age with a diagnosis of low back pain who did not. So this is another one who did not have an imaging study. So a plain X-ray, an MRI, or a CT scan within 28 days of the diagnosis. Applies to the first episode of low back pain in the measure period. So low back pain ranks among the top 10 reasons for patient visits to internists and is the most common and expensive reason for work disability in the United States. Low back pain is a second only to upper respiratory problems as a symptom-related reason for visits to a physician. So the numerator population includes patients without an imaging study conducted on the date of the outpatient or emergency department visit, or in the 28 days following the outpatient or emergency department visit. So what that's explaining there is if a patient walks into an emergency room complaining of low back pain, and this is their first visit of complaining this, we don't want that emergency department to do X-rays, MRIs, or CTs. So protocol says that they need to wait the 28 days. So you want to make sure that you document the low back pain diagnosis and complaint when the patient is in the office. In the event they return after 28 days, the diagnosis is already in the system. Collaborate with your ER physicians on this. Counsel patients on conservative measures using Choosing Wisely guidelines. So printing out these Choosing Wisely guidelines and just explaining to the patients why they shouldn't do this and the protocols that are set in place and how they're beneficial to the patient will be imperative here. They exclude patients with a diagnosis of cancer anytime in their history, or patients with a diagnosis of recent trauma, IV drug use, or neurologic impairment during the 12-month period prior to the 28 days. They also exclude patients with a diagnosis of low back pain within 188 days prior to the outpatient or emergency department visit. So there's a lot of things that excludes patients. Make sure, again, you're reading the guidelines and you understand how it's all set up. All right, when we look at preventative care screening, tobacco use, this is something I believe everybody is doing now, but what you want to make sure is that it's for all patients 18 years and older. You're seeing at least 2 visits or at least 1 preventative visit during the measurement period. So you're assessing if a patient is using tobacco. This includes any type of tobacco. If they are a user, you want to make sure that you're providing some sort of tobacco cessation intervention. This can include brief counseling, 3 minutes or less, and or pharmacotherapy. The CDC and the AMA, National Cancer Institute, they all endorse these resources. Many commercial payers have programs as well. To meet the numerator compliant, you want to make sure that patients who were screened for tobacco use, and this is at least within 24 months, so this is a 2-year look back, and who have received tobacco cessation intervention if identified as a tobacco user. I believe most EHRs now make you ask if somebody is a tobacco user almost on every single visit. So just make sure that if they are identifying that they are a tobacco user, that you are giving them sort of cessation counseling and that you have documented that in the patient chart. That has to be done every 2 years is what it's saying. All right, so this is just a quick snapshot of what the ECQMs look like in a chart with their groupers. All 14 measures together are displayed here. Practices are strongly encouraged to monitor and submit all the CPC Plus measures in the event that 1 or more measures are removed from the list. We've already talked about this, that if they change the criteria behind one of the measures, that they could pull it out from one of these. So if that was one of yours that you were really focusing on, it could harm you. So again, try to focus on all 14 if you can. This gives you a cushion if CMS removes the measures and you have selected the minimum measure or the ones you were most successful at. Failure to report even the 9 measures will impact eligibility for the incentive payment and ongoing participation in the model. All right, so when we look at reporting measures, so you have to report data for the entire performance period. All patients, all payers, and uninsured who were seen 1 or more times at the practice during the period. You must pay attention to the technical and measure specifications to know what to report. Many of the ECQMs require more than 1 numerator, so race, payer, gender, ethnicity, and other supplemental data. Practices must report via one of the following submissions methods. You either attestation in the CPC Plus submission portal, or an electronic submission of a Quality Reporting Document Architect 3 file, so the QRDA 3 file, through the Merit-Based Incentive Payment System submission. You will submit between January 1st of 2018 and February 28th of 2018. So you will complete your full reporting measures from the beginning of the year to the end of the year, but you won't start submitting until January 1st through February 28th. As a reminder, you may want to keep your hard copies of all your data submissions or electronic copy for 10 years in the event of an audit. CMS will annually publish an ECQM handbook, and CMS will provide the website links and instructions prior to the submission period. Again, all measures must be reported at the CPC Plus practice site level. Practice site level reporting should include all patients, all payers, and the uninsured who are seen 1 or more times. So all patients, all providers, and done at a practice level. All right, payments. CPC Plus uses the quality and utilization performance measures to assess improvements in the quality of care over time. The results impact annual adjustments to the performance-based incentive payment that practices may receive. Practices that do not meet the annual threshold would be required to repay all or a portion of the prepaid amount. Practices will thus be at risk for the amounts prepaid. So again, you're getting that money up front. You need to make all the requirements that CMS is asking you to do in order to keep all that money that is there. That's why they're considering it at risk. There's two distinct components. There's quality, which includes the patient experience, survey results, and performance on ECQM. The utilization component will be based on Medicare fee-for-service attributed beneficiaries claims for inpatient admissions and ED visits using the HEDIS guideline measure specifications. So you've seen these slides before, the performance-based incentive payment. This is a breakdown of the prospective payments in the per member per month that practices will receive on a quarterly basis. CMS will prospectively pay and retrospectively reconcile a performance-based incentive payment based on how well the practice performs on patient experience measures, clinical quality measures, and utilization measures that drive total cost of care. Practices are thus at risk for the amounts prepaid. Payment is broken into two distinct components, which we just talked about, utilization and quality, scored and financially reconciled separately. The CAP survey results will contribute 25% to the score, and the ECQMs will contribute to 75% of the score. Practice performance is measured against absolute performance threshold benchmarks. They have not been released yet. Performance benchmarks will be derived from external data, meaning a population external to CPC Plus participation. The practice's actual performance compared to the external benchmark determines the amount of money the practice keeps. So in the next 30 days, what do we need to be doing? You want to make sure that you've chosen your measures ASAP. Make sure the measures pertain to your patient population and can be supported and reported through your EHR. You want to identify and understand internal and external data sources and reconcile it to ensure accuracy. Over the next 2 to 4 months, you want to implement evidence-based care at disease-specific and at preventative care levels to start closing gaps in care. You want to align each measure with its function. For example, you have Function 2, care management, which requires emergency department and inpatient utilization follow-up. Identify your main hospitals and work with them to receive patient discharge notices, reports. You want to know your specifications. Function 5, plan care and population health. Align your quality measures with evidence-based care panel management for population health outreach. Implement a workflow process to use data in your day-to-day patient care. For your next step, you want to conduct population-level reporting. So if you've already identified your ECQMs, you should be reporting, pulling reports out of your EHR to see where you're currently at. What are my numbers in the denominator, and what do I need to close? You want to verify that the patient data is accurate. You want to compare it to the previous year or the previous month even. So is my mapping going correctly within my EHR? Your evidence-based guidelines, are they at the point of care? Do I have point of care alerts for all of these measures? Or do I need to develop a new process around it? You want to develop disease-specific patient protocols to close gaps in care. You want to fine-tune workflow issues. You want to assign roles and responsibilities. So operations workflows and clinical workflows. So those can be two different things. You have operation workflows when it comes to pulling reports or notifying patients, and you have clinical workflows of what is the protocol, the evidence-based care measures on taking care of the patients, and how are we identifying these patients in our EHR as well. You want ER and inpatient workflows. Who is going to call? What are the most used hospitals? Do we establish reporting relationships with them? You want to start training your staff on interpreting payer reports and internal reports that you're pulling, and you want to incorporate these in your workflow. You should be holding weekly care team meetings to discuss what is working and what isn't, and some of the patient issues. Remember, this isn't just your Medicare patients. You are doing this for all payer, all providers. So having those team meetings will be crucial. So as we look for practice transformation support, there's significant upfront payment to invest in practice transformation activities. So you're getting those quarterly payments to help you implement some of these things. You could use these to hire additional staff and training that's related to improving care coordination, implementing data-driven quality improvement, and enhancing targeted support to patients identified at high risk. You must show additional payment was used to support additional staff and training, otherwise you lose this revenue. So we just talked about a lot of reporting that needs to be pulled, a lot of patient follow-up that needs to be followed up between appointments or getting patients in. This can all be subsidized by the payments that you receive quarterly.
Okay, wow. Thank you, Shelby. That was a lot of information. Great job as always. We're going to pause for a moment and take some questions. We've got a couple that have come in over the course of the session here. And again, if any of you have additional questions to submit, please use the little chat window in the GoToWebinar control panel. The first is, well, there are a couple here around ER visits. So let me just kind of paraphrase. If a patient goes to the ER, then is admitted, will the ER visit count?
So no, that would not. They would count as an inpatient hospital admission. So they wouldn't be counted in the ER visit. They would be counted in the inpatient one. So they're not counted twice on that. Okay,
and then a follow-on, will UCC visits count as an ER visit?
No, those do not count as an ER visit.
Okay, very good. Let's see, you mentioned that some measures have multiple reporting requirements and they all must be met. Can you give an example?
Yeah, so one that I'd like to talk about is the depression remission after 12 months. First, you have to confirm that the patient has a major depression or dysthymia. So that's your first protocol. And then you have to find out and confirm that the patient had an actual PHQ-9 done and that the score was above 9. Then the next thing you have to prove is that you had a follow-up score that you ran a PHQ-9 and it was less than 5. So that is how it works.
Okay, very good. Here's another question about training. If a physician is putting 10 hours a week for training as a leader, team leader, can he or she be paid for the time, for the training time?
So I guess I would have to ask, is this a question that you're saying that you're using your quality payment for? If the physician is training their staff to implement quality measures, doing that sort of thing, I would say yes, as long as you can prove that that's how they're using that money.
Okay, very good. So with that, let's wrap. There have been a couple more questions that have come in, but we got to start to wrap. So let me just talk a little bit about Medical Advantage Group. We recognize many folks on the line with us here are already very familiar with Medical Advantage, but for those who are not, we're a healthcare consulting company with 20 years of experience helping practices succeed. We're basically helping practices perform in value-based contracts as well as providing any number of practice transformation kinds of services, including CPC plus consulting services. We transformed a ton of practices in both Michigan and Ohio. We're a very large participant in the largest PCMH network in the U.S. here in Michigan with Blue Cross Blue Shield. And for those of you joining us from Ohio, we're a key implementation partner of the GLPTN grant, helping Ohio practices transform for MACRA. There is much more information available about our CPC Plus services. The link to get to that information is available there on the screen. We're basically providing support across all of the dimensions of the CPC Plus program. Shelby talked a lot about the quality element here today, but whether it's quality, care management, healthcare IT, we referred a number of times to EHR capabilities, requirements that are going to be needed. That's another big area where we're available to help. So please just let us know. And then finally, If you would like to talk to us, we'd be happy to set up some time. For those of you in Ohio, the contact is Sherry Kent. Her information is there. And for those in Michigan, Kevin Burke is the contact, and you have his information there. Again, as always, I'd like to thank, first of all, Shelby for doing a great job leading us through a lot of very detailed material here today. Thank you very much. Thank all of you for attending. We appreciate your participation. We will be following up later today or tomorrow with a copy of the materials, recording of this particular webinar. We will also, for the questions we didn't get to, we'll document those answers and share with the entire group. We also will be continuing this webinar series into the month of February, just based on the level of interest and the demand. So in our follow-up, we'll also include an additional set of topics and dates, invites to future webinars. So with that, thanks again. Enjoy the rest of your day, and we'll be in touch soon.